Congratulations to Professor Kim as well for your Lancet publication again, because I will also start your previous publication, host exam, first. But I would like to take the disadvantages as the speaker come after you to ask you maybe two small questions. Did you take, why you still let the doctors to make the decision whether the aspirin or clopidogrel are used after DAPT? Whether had they ever considered the clopidogrel as the main recommendation, because it's very important, I think. Whether you checked the etiology of bleeding, maybe later on you can tell us a little bit more, and how was the proportion of the PPI were used for this patient to prevent gastric intestinal bleeding. I think that would be quite important, especially for this elderly patient. I think the gastric bleeding would be one of the major bleeding risk. But I would like to focus on, because it's a quite big, major topic, and I would like to focus, probably a little bit overlap as what you mentioned, how short DAPT duration could be, the updates and insights of antiplatelet strategy after PCI. Yes, as what you mentioned, we have to balance the bleeding and ischemic risk, especially for the Eastern Asians, because as you can see, we probably are less beneficial from the antiplatelet treatment, especially intensified antiplatelet treatment, but we will show a little bit of high bleeding risk. So probably the sweet point is slightly different compared with Westerner as the Eastern Asians, as you also showed as the last slides of this presentation. But according to us, we already know that actually we could, for the general patients, we can shorten the DAPT to 1 to 3 months after revascularization. We have this quite nice individual patient data level meta-analysis to. So I think the key message one is the balance, as what you mentioned, to balance the ischemic risk and the bleeding risk. And we actually know for so many years, I think from the Capri study, that we already know that for the primary prevention cohort, the clopidogrel at that time as the only one P2Y20 inhibitor showing better outcome compared with aspirin. But at that time, it was quite expensive. Accessibility is a problem, but the number need to treat to prevent one single myocardial infarction was 244. That's why I think this study had never been catch the attention of the general cardiologist. But then come after with your study, host exam, as you can, of course, I think all the audience are very familiar with this study. After the 6 to 12 months of DAPT after the PCI, compared with aspirin, clopidogrel show not only decrease the bleeding risk, but also decrease the ischemic stroke, ischemic risk. So that's a dual beneficial effect. Actually, caught a lot of attention during the release of this study, and also the extended period of such a study shows the similar results, convinced or validate the previous conclusion. But then we also have this individual patient data meta-analysis to compare for relative stable patients, to compare the clopidogrel, not only in clopidogrel but also P1, these three, but mainly for the clopidogrel compared with aspirin. We show the similar results as the host exam. It shows that not only can decrease the bleeding risk, but also show the reduction of myocardial infarction, the bleeding risk, but also shows the beneficial effect of the prevent myocardial infarction, similar results as a host exam. So I think the key message too would be for the further trials, we need to thinking about maybe we just to stop the aspirin first to simplify the decision making, not only for the clinical relevance, but also for the further studies. That's one thing I would like to propose. And the second, and then how long should be this DAPT continue? As you can see, generally we believe that the first, even for the Q study, we can see that actually for the first 1 month, and they have the relative high the ischemic risk, but for the bleeding risk will last for the lifelong time. And probably that's give the rationale for us to thinking about to decrease the DIPT for only 1 month for the general participant. There's also some study to show that for the stop DIPT2 from the Japanese colleagues, they show that for the all comers to do the PCI in Japan and compare with the clopidogrel monotherapy for 1 month, compare with the general 12 months DIPT, we can see that decrease the NES, including both ischemic and bleeding risk. But when it comes to the ACS subgroup, as you can see here, for this ACS group, actually will increase a little bit the ischemic risk. And then they also, actually at the beginning, they already prepared for to merge the subgroup of the ACS cohort and enrolled a little bit more ACS for the stop DIP2 ACS study, which shows actually for the ACS relative high ischemic patients, we have relative high the incidence of ischemic risk. Of course, we also show that it decreased a little bit the bleeding risk, but then the overall, the NAS effect, the non-inferior, the hypothesis had never been confirmed in such a study. So maybe for ACS patients, 1 month DIPT following with clopidogrel might be risky for the clinical and also for the further studies we need to thinking about. But then there are some other colleagues just published the target first and also simultaneously released the result in ESC meeting this year, compared with the dual antiplatelet conventional duration compared with the P2Y12 inhibitor monotherapy for 1 month, even for myocardial infarctions, it shows that the effect of decreased bleeding risk, but also similar to prevent ischemic risk. But we have to notice that they only focus on those with relatively low risk. They exclude those myocardial infarction patients with, for instance, complex PCI or chronic or left main coronary artery disease and received stents longer than 8 centimeters in lungs and so on. And therefore, and also we have to also to notice that for these patients, they mainly used ticagrelor instead of clopidogrel in these patients. That actually convinced to us maybe clopidogrel would not be good enough. But then whether clopidogrel, the ticagrelor will be good enough for 1 month DIPT. Actually, we can already learn from the global leader study. Of course, at the beginning, this study was quite ambitious. They are not only to prove for 1 year shortened to DIPT, continue with ticagrelor will be better with the conventional depth treatment, but they also would like to promote maybe ticagrelor extended treatment compared with aspirin treatment. And of course, I think the main study was negative and non-significant. But if you look at the landmark of 1 year analysis, you can see that actually 1 year DIPT following with ticagrelor will be good enough for this patient to prevent ischemic risk, but can decrease the bleeding risk dramatically. And what then we also can learn from TWILAT study for the high-risk PCI patients, shorten DIPT to 3 months following with ticagrelor would be fine compared with conventional 12 months DIPT treatment. And shorten, and also that conclusion had been mainly duplicated or convinced in the Korea population as well in TICO study. They used relatively new stents, but enrolled 1/3 of them are the participants, 1/3 of these participants are American myocardial infarction patients. What we can see that compared with conventional 12 months DIPT, ticagrelor monotherapy after 3 months DIPT will be beneficial concerning with both bleeding and bleeding and ischemic risk. If you look at mainly for the bleeding risk, of course, dramatically shorten to 3 months, DIPT will dramatically decrease the bleeding risk, but to remain a similar effect to prevent ischemic risk. But then also last year, I think it's also released in ESC, they published this individual meta-analysis, individual data, individual participants data meta-analysis to actually compare with shortened DIPT, 1 to 3 months, compared with a conventional DIPT. In the ACS patients, ticagrelor will play in a very good game. And then the key message 4 I would like to mention is for the chronic coronary syndrome, 1 month DIPT following with any P2, Y12 receptor will be fine, except for those with relative high risk and very extremely high ischemic risk. For the ACS patients, generally maybe 1 month DIPT following with T, but not really clopidogrel. Ticagrelor will be fine, but not really clopidogrel. That's the data we learned from Stop DIPT-2 ACS study. Could the duration be even shortened to less than 1 month? We can also learn from TPAS study from Korea colleagues. They also compared with later the principal investigator to decide, the doctor to decide when will stop the aspirin after the DIPT within 1 month. And then the median DIPT period was 16 days. What we can learn here for the non-impaired analysis was significant. It's also show for this next event, the shortened less than 1 month DIPT following with ticagrelor will be more beneficial compared with conventional 12 months depth treatment. And it was mainly driven by the major bleeding risk decreases along with this monotherapy. But then whether we can stop, whether we at the really beginning, we just only use one ticagrelor or clopidogrel or prasugrate treatment at really beginning. That's one of the study published in ESC, presented. I didn't see actually the publication of this study yet. They compared in the Brazil, 50 sites in the Brazil, they enrolled ACCR patients had this the PCI procedure after the ACS within 4 days and randomized to either monotherapy or with conventional DIPT treatment together with aspirin. And then check the follow-up them until 12 months to check the primary ischemic outcome together with the primary bleeding risk. Of course, I think bleeding risk will dramatically decrease, but the ischemic risk is also very high. But even this study, many are using prasugrate, and 1/3 of them are using ticagrelor. Very few are using clopidogrel. So maybe even by using more potent P2Y12 inhibitors, stop DIPT at the really beginning will not be good enough. And we also can learn from such a study, even can learn from Plato study, from CURE study, and also from the Neumann study. You can see that actually the risk, the difference between these two groups are mainly driven the risk at the first month. Afterwards, these two lines are quite parallel to each other. There's no further increases of risk along the rest of the following time. And they are also focused on the prasugrate monotherapy. There is a pilot study, is one-arm pilot study enrolled the PCI patients. They just use prasugrate, and actually it shows that there is no ischemic risk by using the monotherapy at the really beginning without any DIPT period in such a population. But then we are waiting for randomized 2 arms trial, but we didn't see any results, further results. But then our Japanese colleagues also did the similar study in the Japanese population and shows the similar results. But we have to notice that actually the Sugrate dosage in Japan was generally very low. They are using 3.75 milligram per day, compared with the rest, especially the Western countries, generally are using 7.5 to generally 10 milligram per day. And then they also did the stop diabetes 3 study by using procigarate monotherapy at the really beginning compared with conventional depth study. But the dosage, as what I mentioned, is still using the small dosage because we worry about in the Eastern Asians, maybe we have relative high risk even by using procigarate 10 milligram per day monotherapy. But what we can learn from here, the similar risk between these two groups. But then we have relative high the intrastent thrombosis risk, not only for acute, but also for the subacute risk also high compared with these two groups. So that means maybe at really beginning, without any DAPD treatment would not be good enough for PCI patients, any type of PCI patients. What would be the take-home message from my perspective? I think maybe we really need to classify or have the classification of ACS compared with CCS. They are different. And we have to balance the bleeding and ischemic risk, of course. And maybe complex PCI or different stents would play a role to modulate the risk. But actually from the previous studies, we see that actually the shortened DAPD treatment shows the similar reduction, the bleeding risk, and similar results to prevent ischemic results compared with the interaction between the shortened and the conventional DAPD treatment with the complex PCD or different stents shows the similar results. That means maybe the PCI procedures or different stents are not really a very good player for this risk prevention. And of course, I think the P2Y12 inhibitors are very important, as I showed to you. And for the patients after CCS PCI or all PCI procedures, switch P2Y12 inhibitor monotherapy at 1 to 3 months post the procedure would be feasible, both for ticagrelor or clopidogrel. We have less evidence for prasugrate. For patients after ACS PCI, switching to ticagrelor monotherapy at 1 to 3 months post the procedure or continuing clopidogrel-based dual antiplatelet treatment for up to 12 months would be recommended. And does monotherapy have a future in antiplatelet treatment? If monotherapy is adopted, what would be the optimal dosage? I think the dosage, as Professor Kim also mentioned, that one dosage or one fit for all might not be a good choice. So one set fit for all and with fixed dosage, maybe in the future we need to thinking about according to for some measurements, some parameters or the risk balance we need to thinking about. Maybe some new medications can help us to prevent the risk during the first months. For instance, the self-injection formula, the cilitagrate, to prevent the macula infection in the first months, probably at really beginning with the monotherapy might be feasible in the future. Thank you very much.